So we have the topic, the benign prostatic hyperplasia or BPH. It is most common disease in male after 40 years old. So we have seen the anatomy of the urinary system of males, the physiology, what is BPH, and its diagnostics and treatment. So we have the subtopics anatomy and physiology of the urogenital tract to understand what part takes the prostate gland in the whole urinary system and reproductive system. Also, what is BPH, its pathological changes in the prostate gland, the diagnostics, the surgical treatment, and drug treatment or conservative treatment. So here we have the anatomy of the lower urinary system. It contains the ureter with ureter openings, detrusor muscle of the urinary bladder, the urinary bladder triangle where is going the BPH when it is exists and enlarges own prostate gland, the vas deferens duct inside the prostatic part of the urethra, and internal sphincter and external sphincter, which are also takes the part in the micturition of the males. So we also have the vas deferens. The urethra begins in this part of the urinary bladder. The ejaculatory duct, which also can be traumatized after the surgical treatment like transurethral resection. We will talk a little about it later. So seminal vesicles near the prostate gland, own prostate gland, the sphincters, internal sphincter, bulbar glands, urethra, and spongy bodies of the penis. Prostate gland contains the prostate capsula, the glandular epithelial tissue, prostate duct lumen, and fibromuscular or stromal tissue. So prostate gland takes the part in creating of the ejaculate volume, regulates the pH of the sperm, gives viscosity to the semen, serves as a medium for the spermatozoa, and helps to liquefy sperm after ejaculation. The physiology of the urination. So we have the scheme of the normal micturition process. So at the first stage the bladder fills, where the detrusor muscle relaxes and pelvic floor muscles contracts. When the urethral sphincter contracts, we have the first sensation to the void when the bladder is half full. It is about 100 milliliters or up to the 150 milliliters. Then we have the normal desire, where we have the filling of the bladder about 200 milliliters. And here we can see the situation when we start the micturition. The detrusor muscle contracts instead of relaxes, and the pelvic floor muscles also relaxes, but urethral sphincter also relaxes. The voluntary control begins. And after micturition, the urethral sphincter contracts and the detrusor muscles relaxes instead of the contractings due to the micturition, to allow the urine to come out from the urethral orifice. So innervation of the lower urinary tract connects by controls by the parasympathetic system, cholinereceptors M2, M3, the sympathetic system, which controls by adrenoreceptors, and alpha-1D adrenoreceptors, and alpha-adrenoreceptors, predominantly alpha-1A, which are located in the bladder neck, prostate, prostatic urethra, and urethral sphincters, and also the somatic system, which also controls the process like micturition or urination. So here we can have more wide nervous controlling system of the urinary blood of the urination. So firstly the impulse of the urination starts from the cerebral cortex and from the pons. Then it is going by the peripheral neural system, by the sensory receptors and also the motor receptors. So it also makes the detrusor muscle contracts or relax the stretch receptors to be stretched due to the filling of the bladder, and also the working of the internal and external sphincter and urethra controls by these receptors, and also by the somatic motor fiber of the pudendal nerve. So here's the benign prostatic hyperplasia and how it is change the size of the prostate gland, and you can also see the size of the mucous layer of the urinary bladder, and also the internal view of the urinary bladder with the lots of the hypertrophic changes in the mucous layer. So here looks like the normal urinary bladder and the prostate gland. We can see the smooth shape of the mucus and also not so big size of the prostate gland. Here we can see the BPH with increasing of the prostate size, and also the changes in the mucous layer of the urinary bladder. It is thick instead of the thin in normal, and also with the lots of the hypertrophic lesions in the inside area. So the benign enlargement of the prostate gland due to the proliferation of the glandular and the stromal components. The midline lobe extends into the base of the bladder. The prostatic urethra becomes narrower and the bladder wall thickness. There are all signs of the BPH. Etiology of the BPH. So we have the physiological situation which are non-modifiable, like age, genetics and geographical situation, and modifiable like hormones, testosterone, dehydrotestosterone, estrogen, metabolic syndrome, obesity, diabetes, diet, physical activity and inflammation. That's all factors that we can change due to the observation of the patient with the BPH. The pathogenesis of the BPH. So we have the prostate size, the static component of the and mechanical obstruction. By the alpha-1 adrenergic tone, the dynamic component and functional obstruction is controls. Due to the situation when we don't have the ability of the urine bladder to control the urine outflow from the lower urinary tract due to the BPH, we have the problems with the infravesical obstruction. So its obstruction increases the intraurethral resistance, and we have the symptoms of the voiding like obstruction, and also we have the physiological reaction on this pathological state like detrusor adaptation, which makes that it decrease of cholinereceptor density, transition from the beta to alpha adrenergic type of the density, and also the hypertrophy of detrusor and detrusor fibrosis are become as the physiological reaction to the obstruction and lower urinary tract symptoms. And this situation with the detrusor adaptation makes the detrusor overactivity and makes the symptoms of the feeling like the symptoms of the irritation. So if we have the patient who suffers from the BPH for prolonged time, even after the surgical treatment, we will see the situation with the symptoms of the feeling and irritation. Because we have the changes already changed the mucous layer of the urinary bladder and also its neurostimulation, and even after the surgical treatment we can see that for the prolonged time, about 6 months or 1 year, the symptoms of the patients of irritation. So he wants to urinate very frequent times. And so this one is the symptom which we should control even after the operation and make the good conservative treatment. Epidemiology. So we can see on this scheme that we have the most frequent situation with the BPH in men after 80 years old. But it is quite close after 65, and we should observe these patients also on the BPH and to check his state of the urination. And here we can have the symptoms of the emptying and symptoms of the filling. So in the symptoms of the emptying, we can see the difficult onset of the bloating or of urination, sluggish urine flow, intermittent flow, dripping at the end of the urination, and feeling of incomplete emptying. The dripping at the end of the urination, it means the leakage after you end the urination of some drops of urine. The symptoms of the filling, we can see due to the filling of the bladder with the BPH. The pollakiuria means the frequent urination more than 8 times a day. Nocturia means the frequent urination at night time more than 2 times a day. Imperative urge means that we have the urge to urinate, which we need to control very hard. And urine incontinence when we don't feel the urination due to the this process and can control it. The weak urine flow, about 56%, and feeling of incomplete bladder emptying, about 53%. These complaints are the main, and the doctor urologist decides what to do to get to take the medicine for the patient or to make the surgical intervention. So, natural course of the BPH. First of all, the BPH is slowly progressing disease. So if we have the BPH without any symptoms, we shouldn't make any conservative or a surgical treatment for this patient. However, not all patients progress. There are cases of stable course and improvement without treatment. And progression occurs to varying degrees in different patients. So this is the most important in the clinical management of such patients, because we need to get the proved indications for the surgical treatment or conservative treatment, because lots of the patients has the BPH but they don't have any symptoms and don't suffer from this at all. And our intervention by the medicines or surgical treatment also have own complaints. So we need to decide what is better for this patient and how to get better their quality of life. So BPH is not life-threatening, but the clinical manifestation markedly reduced the quality of life of the patients. This is what we can change in these patients with the BPH and symptoms of it. The complications of the BPH can be the acute urine retention, means that the patient wants to urinate but he can't. The chronic urine retention, when the patient urinates but after 15 minutes or even earlier, the patient wants to urinate again. Urinary tract infection, which means the collection of the bacteria due to the chronic urine retention, and also the complications of this in bacteriuria with the inflammation. Bladder diverticula, hematuria, the presence of blood in the urine, bladder stones, which exist due to the chronic urine retention in the urinary bladder. It is primary stones. Urethral reflux, due to the situation of the increasing of the urinary bladder pressure, hydronephrosis, the transformation of the pelvic coliacal system from the upper urinary tract, and the chronic renal insufficiency as a result of the prolonged situation with the urethral reflux, infection, urinary tract, and also the chronic urine retention. This situation never treated by surgical methods, because we can make the big and serious problems with the patient's state during the operation or after operation if we have the chronic renal insufficiency. So diagnostics of the BPH. On the basis of the signs of is the diagnosis of the BPH made. First of all, the presence of the symptoms of the lower urinary tract dysfunction. That means that we have the obstruction, the frequent urination, the weak stream of urine and other. The prostate enlargement, and also the signs of infravesical obstruction, which means that the presence of the residual urine more than 50 milliliters. We also evaluate the lower urinary tract symptoms by the International Prostate Index score, where we have the test with the points, and also we collect all these points and makes the stage of the BPH. So here we have the lower urinary tract scores. From the 0 up to the 7 we have mildly expressed symptoms, from the 8 to the 19 moderately expressed symptoms, and from the 20 to the 35 severe symptoms. So we make the any surgical treatment from the 8 up to the 35, and mildly expressed symptoms can be treated by the conservative treatment. The digital rectal examination helps us to evaluate the size of the prostate, the consistency of the prostate, its shape, medial furrow, soreness, and mucosal motility. So in the BPH, the prostate is enlarged, symmetrical, elastic, and painless. The prostate cancer show us, due to digital rectal examination, the compacted, uneven, bumpy, asymmetrical mucosal immobility of the prostate. And acute prostatitis show us the swelling of the prostate gland and sharply painfulness due to the palpation of the prostate. The enlargement of the prostate gland involves also the assessment of the size and contours and anatomical position of the BPH by the ultrasound, the transabdominal and transrectal. We can easily see the prostate gland with enlarged sizes and signs of the BPH by the transabdominal investigation. But if we have some problems with the tissue of the prostate and its changes and signs of the prostatic cancer, we should make the transrectal examination of the prostate gland. So enlargement of the prostate gland we also can see during the urethral cystoscopy, radiological examination, CT scan, and MRI. The infravesical obstruction is evaluated due to the such investigation like Uroflowmetry, which assesses the speed of the urine stream, which can be with maximal speed and average speed. And if these indications are low, we should think about the infravesical obstruction. So here we have the flow rate and also these indications: voiding time, flow time, time to max flow, a max flow rate, average flow rate, and voided volume. The uroflowmetry assesses by Qmax less than 10 milliliters for the second is 90% availability of the obstruction. The Qmax from 10 to the 50 milliliters per second, it is 65% of the presence of the obstruction. And Qmax 15 milliliters per second is the 30% presence of the obstruction. The laboratory research makes the general analysis of the urine and general blood analysis, or biochemical blood analysis if we have the indications. So the analysis of the urine can show us the urinary tract infection and the presence of the hematuria. The blood analysis can show us the urea and creatinine levels, which is very important for the possible kidney damage if we have this one due to the increasing of the creatinine and the urea. And also the PSA level, the prostatic specific antigen, which is show us the presence of the inflammation or the prostate cancer if it is increased very much. So the prostate specific antigen is oncomarker of the prostate cancer, and we have the reference range. Here we have from the 40 up to the 49 is up to the 2.5 nanograms to milliliter. From the 50 up to the 59 is up to the 3.5 nanogram to milliliters. From the 60 up to the 69 is up to the 4.5 nanogram to milliliters, and from the 70 to the 80 is up to the 6.5 nanogram to the milliliters. So we have the Hald diagram, how would describe the relationships between the bladder outflow obstruction and lower urinary tract obstruction. We have the lower urinary tract symptoms, bladder outflow obstruction, and BPH. And the BPH is in the middle of the lower urinary tract symptoms and bladder outflow obstruction, which also can make the quality of life of the patient is very low. So we need to check this patient and trying to help him with surgical treatment or conservative treatment. So dynamic observation for the patients. If the ideal patient for the dynamic follow-up is one who has no complications at the initial examination and has minimal complaints. The I-PSS scale is about up to the 7. The patients on weight and seat tactics are from the 8.3% in the Spain and to the 47.4% in the UK. It depends on the level of the medical help in the countries. So in big countries where we have the good medicine, the government tries to detect the diseases in early stages and to help for the patient or to make the prevention methods. It also helps for the people who live in this country to stay in the good shape and to work for a long time. So it also helps for the economy of such countries. The surgical treatment is made in the most cases the complete or partial removal or the hyperplastatized tissue. The surgical treatment has the absolute indications for the surgical intervention, and the most common reasons for the surgery in practice are the complications of the benign prostatic hyperplasia and also the significant symptomatology. So we have seen this in the previous slides, and what types of the surgical treatment we have. First of all, transvesical prostatectomy or open prostatectomy. It has the complete removal of the adenomatous nodes, the maximum effectiveness, and can be performed in all prostate sizes. But it has the highest risk of the complications: bleeding, inflammatory complications, suppuration of the postoperative wound, erectile dysfunction, retrograde ejaculation and thromboembolism, and also the prolonged term of the hospitalization due to the situation with the open operation type. Nowadays we have made the operation which is the gold standard in the all treatment of the BPH is the endoscopical treatment. So endoscopic treatment has the less trauma, the fewer complications and faster rehabilitation. But it also has some problems, like the gland size should be up to the 100 cubic centimeters. The specific complications like the Tour syndrome, technical limitations, and there is not always material available for the histological examination. Actually, for now it can be, so it is not problem for the histological examination. And high cost was before, but now it is in the same price like the open prostatectomy. The thermoablation and thermodestructions are the alternative methods of the treatment. So we have the more than 70 degrees like radio frequency transurethral thermal destruction and transurethral focused ultrasonic thermal ablation. Also we have the thermotherapy like microwave and radio frequency transurethral thermotherapy, and hyperthermia like transrectal microwave hyperthermia. All these alternative methods we do in rare cases due to the situation with the cost of these procedures, and also we have the good results due to the transurethral resection. Choice of the treatment. The choice of treatment of the methods not only on the clinical situation but also on the skills and the preferences of the urologists, the technical equipment of the clinic. And also, as with the other methods of the treatment, the decision about surgical treatment must be based on the patient's own ideas about the effectiveness and risk ratio. So here are the transurethral resection of the prostate. the tool with name of resectoscope inserts by the urethra inside and going to the prostatic part of the urethra with the BPH. Then with the loop we try to resect piece by piece the BPH parts. Here you can see. And then after this operation we insert the catheter fully to prevent the post-inflammatory swelling of the prostatic part of the urethra and to make the good urine pathway after operations. Also to control the urine outflow, its daily diuresis and the color of the urine. The treatment of the BPH, the medication therapy. So we have the groups of the drugs for BPH treatment. The herbal medicines like phytotherapy, the 5-alpha reductase inhibitors, alpha blockers, and 5-phosphodiesterase inhibitors. So 5-alpha reductase inhibitors like finasteride and dutasteride. They have own effect on the decreasing of the size of the prostate gland with BPH, with making of the transformation of the testosterone to dehydrotestosterone. Recommended by the international guidelines for the treatment of the BPH for patients with the mild and to moderate symptoms. Effective with the proper patient selection, increase Qmax by 18% and decrease the I-PSS scale by to the 26%. Pathogenetic treatment with anti-androgenic effect with the reduction of the prostate size by 20%. Suppresses the development of the hematuria against the background of the BPH, probably due to the action of on the vascular epithelial growth factor. Long-term efficiency makes it should be treated by the few years. The effect on the disease progression with the reducing the incidence of the acute urine retention and surgical interventions with the prolonged usage. Convenience of use once a day and no need for the dose titration, and also no drug interactions. Finasteride, decrease in PSA levels by 50%. Good effect only on the prostate size more than 40 grams. The side effects are effects on the sexual function, the decreasing of the libido, ejaculate volume, erectile dysfunction, and gynecomastia. The slow onset of the action, it starts to have the effect after the treatment for the 3 up to the 6 months. Effects only on the static component, obstruction with the prostate size can be effects only directly on the symptoms of obstruction, and efficiency somewhat lower than alpha blockers. The alpha blockers has own effects and has own action. So the positive effects of alpha blockers are rapid onset of the action. This makes it possible to use the drugs in the following cases. During surgical interventions for the BPH and other diseases for the prevention and treatment of the urinary retention, for rapid elimination of symptoms after a number of invasive interventions, act directly on both the symptoms of the obstruction and irritation, and effects on the prostate, urethra, and directly on the detrusor. The most effective treatments for the BPH are alpha blockers and effective on all prostate sizes and no effect on the PSA levels, which also helps us not to mask the situation with the prostate cancer, which also can exist due to the BPH. The alpha blockers have own side effects like orthostatic hypotension, dizziness, headache, fatigue, asthenia, tachycardia, palpitations, fainting, and rhinitis. And the most important side effect and scary for the males is retrograde ejaculation. These side effects can exist due to the overdosaging of the alpha blockers. So the patient should take only once dosage, about 400 milligrams of tamsulosin, if it is tamsulosin, and silodazine is about not more than 8 milligrams. So in these cases the patient will not have side effects and will have the better state due to the improvement of the urination. Alpha blockers, similarities and differences. The efficiency of all alpha blockers in BPH is approximately the same when used in adequate dosages. The differences in the efficacy may be seen in terms of rapidity of the onset of the effect. Drugs that do not require titration act faster. Differences are in safety and convenience for the physician and the patient. Thank you very much for your attention. See you up on the next lesson.